Hello people, this is Dr. Anchal Tandon and we will be discussing MCQ series, and just proceeding to every session of MCQ series will be the session of its detailed discussion through the Robbins book directly. And so to start with, today we are starting Robbins Neoplasia. As it is a very high yielding topic, we are starting the series from Neoplasia. Okay. So to start with, Neoplasia. Neoplasia means a new growth. New growth will contain two types things, that will be the cells, the tumor cells and the stroma. So the tumor cell composed of two components. The one is the neoplastic cells and the other one is the stroma, that will contain connective tissue, blood vessels, adaptive and innate immune response to it that is surrounding it. Okay, along with it, sometimes connective tissue is scant and the neoplasm is soft and fleshy. Okay, then there can also be parenchymal cell stimulates formation of collagenous stroma around the tumor that is called as desmoplasia. And some desmoplastic tumors, some cancers in breast can cause stony heart serous changes. Okay, so what a benign tumor is? Benign tumor is that is localized and is easily surgically removed. So that is called a benign tumor. It is usually suffixed with oma. A fibroblast tumor is called fibroma. A cartilaginous tumor is called chordoma. The one with epithelial neoplasm will be called adenoma. The ones with the finger-like projection will be called papilloma. The one which will have large cystic mass will be called cystadenoma. Malignant tumors. So now malignant tumors. Malignant tumors are the ones that invades and destroy the adjacent structures and also cause distinct spread, that is called metastasis. And then the malignant tumors are named accordingly. If it is of mesenchymal origin, it will be called sarcoma. If it is a blood forming cell, that it is like leukemia or lymphoma. And then if it is of epithelial origin, then it will be called carcinoma. Further, the carcinoma can be a squamous cell carcinoma or it can be an adenocarcinoma, depending upon if it is origin is stratified squamous epithelium or its origin is glandular epithelium. Approximately 2% of the cases, cancers are composed of unknown origin, that we cannot find out what origin it was. Then there are mixed tumors. Mixed tumors are the ones, all parenchymal cells closely resemble each other. Whenever there is a tumor, all cells are nearly of similar origin. But in this classical mixed tumor, what will happen? Especially it happens in the salivary gland. So it will have epithelial component along with myxoid stroma, and it will contain islands of cartilage, bone. So that means it will have variable components, but these all components will be they will be single neoplastic clone and will be produced from both epithelial and single clone has been producing both epithelial as well as mesenchymal. So example is pleomorphic adenoma. And then there is another thing that is known as teratoma. Teratoma is the one that is having the components of multiple lines, like it is having ectoderm, endoderm, either any two of them, minimum of two of them. Then can have three components also, that could have components of ectoderm, endoderm as well as mesoderm. So this is a photomicrograph of the teratoma, which is showing the neural tissue, showing the sebaceous component, showing the epithelium. And then this is a gross picture showing hair component. It was also having some sebaceous component. Then this is a cystic structure. This is a ovary. Okay. So this is showing nomenclature that you can study yourselves. Then we are defining some very important things, that is Hamartoma. Hamartoma is a disorganized mass that is composed of cells indigenous to that area. That means it is present at the normal site, but it is disorganized. It is abnormal mixture of cells that is not present at a normal place. But in this study, it was earlier believed to be a distinct thing, but now it is found that all these cells that are hamartomatous cells, all the cells in this are clonal. So now it is considered as a benign tumor. Then we come to a choristoma. Choristoma is a normal tissue, but it is present at an abnormal location. It is a heterotropic tissue. Rest. Then we come to characteristics of a malignant neoplasm. So malignant neoplasm, first thing is differentiation. Differentiation refers to how much the neoplastic cells is resembling the normal parenchymal cell, both in morphology as well as in function. So it means, suppose there is a tumor and how much it is resembling suppose it is a leiomyosarcoma. So how much is it resembling the normal smooth muscle? That will be its differentiation. So this is a adenoma of thyroid and it is very well resembling the follicles of thyroid. So it is well differentiated. This is a well differentiated squamous cell carcinoma and is very well resembling the squamous cell. It's showing desmosomes and it is showing keratin pulse. That means it's a very well differentiated tumor. Most malignant neoplasms exhibit morphological alterations that betray their potential for aggressive behavior. In well differentiated tumors, these features may be quite subtle. So this is an anaplastic tumor that is showing some cells that are large and oval, then elongated cells, they're having small cells. It is showing tripolar mitosis. So it is a very pleomorphic tumor. So in the heading of anaplasia and differentiation, how will you find out if it is differentiated or not? So we will find it out in these headings, if there is pleomorphism or not. Pleomorphism that we have already seen in the picture, that is some cells are big, some are large, the morphology is having variable size, variable shape. So this can have tumor giant cells, they can have two or more multiple hyperchromatic nuclei. Then there is abnormal nuclear morphology. The nuclei normally has up to 1:4 to 1:6 ratio of its nucleus. That is, then it is 1 time nucleus and 4 to 6 times cytoplasm. Whereas in the malignancy, it becomes 1:1. That is equal amount of nucleus and equal amount of cytoplasm. The chromatin is often coarse and it becomes clumped. And abnormally large nuclei can also be seen. Now we come to mitosis. Mitosis is when we have always seen the cell cycle, but normal mitosis can also be there in a highly dividing cell normally, but we have to see for atypical mitosis or presence of mitosis at a place where it is normally not supposed to be present. Then there is loss of polarity. That means the orientation of the anaplastic cell with respect to each other or to supporting structure like basement membrane is markedly disturbed. Like means if something is horizontal and all cells are arranged like that in the vertical plane, so if we're having loss of polarity, a cell will be arranged perpendicular, one will be arranged in tilted, one will be on the other opposite side tilt. So these will all not be aligned. So this is called loss of polarity. Then there can be other changes like change in blood supply, vascular stroma. Then we come to metaplasia, dysplasia and carcinoma in situ. So what is metaplasia? This is one type of cells will be converted to another type. Like we all know that example of Barrett's esophagus, that is when there is the lining of esophagus is squamous, whereas the lining of the GI, the stomach is columnar epithelium. When there is a repeated episodes of GERD, that is acid reflux into the esophagus, and then there is metaplasia where the squamous epithelium is replaced by the goblet cells and the glandular epithelium, that is known as the Barrett's esophagus, and it increases the risk of malignancy. So metaplasia can increase the risk of malignancy, but it is a reversible condition. It is due to friction, it is due to recurrent damage that it tries to change from one mature form to another. Then we come to dysplasia. Dysplasia is a disordered growth. Disordered growth, cells may exhibit considerable pleomorphism, hyperchromatic nuclei, high NC ratio, all the features that we have studied about them. And then dysplastic says it will also have loss of orderly differentiation. So this cells, but this will all be localized. It will not be spreading out. These all features of disordered proliferation will be very localized. What will happen in carcinoma in situ? This dysplasia is exceeded so much so that it is completely covering the full thickness of the epithelium, although it is still not extending beyond the basement membrane. So it does not permeated the basement membrane, but it has acquired the full thickness of epithelium. The dysplastic changes are often found adjacent to the foci of invasive carcinoma. Okay, nevertheless, although dysplasia may be a precursor of malignant transformation, it does not always progress to a cancer. So that means maybe it can stay confined to a basement membrane and never spread. So this is a photomicrograph showing complete thickness of dysplastic cells that are in the whole thickness, but they are not crossing the basement membrane. So this is carcinoma in situ. This is the similar thing in a high power view. It's just showing a lot of mitosis. Then we see local invasion. The growth of cancer accompanied by progressive invasion, destruction of surrounding tissue is called local invasion. This is eventually spreads, whereas all the benign tumors grow in cohesive expansile manner that remains localized to the site of origin. Lack of capacity to invade or metastasize. So what we will see? There will be a lot of pressure in a benign tumor, whereas in a malignant tumor it will spread out and then it will start to invade instead of creating pressure, and also it will metastasize. The tumor capsule usually consists of extracellular matrix deposited from the stroma cells such as fibroblasts, which are activated in hypoxic conditions. So the next to the development of metastasis, invasiveness is the most reliable factor. So I told you the metastasis is the most reliable thing about the malignancy, when the second most important thing is invasiveness. Then we come to metastasis. Metastasis is defined as spread of the tumor to a physically discontinuous site with the primary tumor. An event that is unequivocally marked a tumor malignant. That means that if there are all the features of that of benign, but something has metastasized, it is labeled as malignant. So the total definition is spread of tumor to a physically discontinuous site with the primary tumor, that is event is unequivocal, marks a tumor malignant. But there are some exceptions in this malignant tumors that only spread locally and do not metastasize, and their examples are gliomas and basal cell carcinomas. Whereas the some that spread out very fast, that are the blood cancers or the leukemias and lymphomas. Overall, up to 40% of tumors when the present are in already metastatic disease. Small, well-circumscribed, slow-growing lesions sometimes metastasize widely. Conversely, some rapidly growing large lesions remain localized for many years. So, the size doesn't correlate, and even the rate of growth doesn't correlate. The path of spread, so they can be a direct seeding, that can be like a ovarian can directly give seedings to the peritoneum. Then they can be a lymphatic spread and the hematological spread. So seeding of the body, it is an open field and most often involve peritoneal cavity, but any body cavity can be involved. That can be pleural, pericardial, subarachnoid, joint space, any can be involved. The tumor cells may remain confined to the surface of the abdominal viscera without penetrating the substance. So we have studied that lymphatic spread is the most common mode in the carcinomas, whereas hematological spread is more common in the sarcomas, but these are not very fixed things. The hematological spread can also occur in carcinomas, whereas lymphatic spread can also occur in sarcomas. So lymphatic spread. Transport through lymphatic vessel is the most common pathway for initial dissemination, that we have already seen that carcinomas it is more in carcinomas, but it can also occur in sarcomas rarely. What is a sentinel lymph node? It is defined as the first node in the regional lymphatic basin that receives lymph flow from the primary tumors. Then it is a hematological spread. Hematological spread is typically of sarcoma, but it is also seen in carcinomas. In general, histological evidence of penetration of small vessel at the site of primary tumor is an ominous feature associated with hematological metastasis. So, if blood vessels are usually, it is metastasizing in a very small vessel or artery. The thicker vessels don't allow it. Then several factors that will affect the pattern of vascular metastasis are: with venous invasion, the blood-borne tumor cells often come to rest in the first capillary bed they encounter. Understandably, the liver and lungs are the most frequently involved hematological because they are very highly supplied by the blood. So, cancers arising in close proximity to the vertebral column will usually embolize to the vertebral column or paravertebral sinuses. So we will see the difference in benign and malignant. So very simple difference. The benign will be well differentiated, whereas malignant will lack the differentiation. Rate of growth of benign is slow, where it is rapid. In malignant, it will show mitotic figures, and this can be present mitotic figure, but it is rare. Then local invasion will not be there, but rather it will be expansile and well demarcated. Then the malignant will have invasion, it will be infiltrating. Sometimes it can also be misleading, as it will be cohesive and expansile, so that conditions can be misleading. Then metastasis is completely absent in benign, whereas it is very frequent in malignant. Now we come to epidemiology of carcinoma, the global impact. So to start with, in 2018, it is estimated that up to 9.5 million deaths were from the carcinoma cancer worldwide. That is 1 in all 6 deaths. Moreover, due to increasing population, the cancer cases will increase up to 21 million, and the cancer related deaths will increase to 13.2 million by year 2030. So to study, we have seen that earlier in the man, nearly 80% of the decrease is seen. Lower death rate has reduced in lungs, prostate and colorectal carcinoma, and in women, nearly 60% of the decrease is due to reduction in death rate from the breast and colorectal carcinoma. So when we analyzed, we have seen the reducing rate of malignancy in the lung cancer. It is due to reduced tobacco intake, whereas the improvement that is seen in the colorectal carcinoma, breast carcinoma and prostate carcinoma is usually due to early detection as well as good treatment. Improved treatment is responsible for decreasing their rate. So it is an important point that in the lung it is usually preventive, because it has a very high rate of mortality, and mostly it is preventive measures that has been effective to reduce the incidence, whereas in the colorectal carcinoma and breast and prostate carcinoma, early detection as well as treatment has helped to reduce the rate. In the last century has also seen a sharp decline in cervical cancer, that is due to there has been screening program, that is PAP screen. Then we have detection of precursor lesions and early and cure. So in this photomicrograph you can see in the woman the highest is for breast, in the men it is highest is for prostate. The lung is 13% in both, but still the highest mortality amongst the cancer, the one if it is asked which is the causing the highest cancer related mortality, the answer for both is the lungs. But the highest incidence in women is the breast, whereas in the men is prostate. But see, in the another photograph, we can see the lung comprise 24% of all the deaths. That is the highest. and 23% in women, that is also highest amongst its all malignancies. The prostate malignancy only got 10% death in spite of being 20% of the overall cancer incidence, and 15% breast in spite of being 30%. So nearly half of the percentage it is causing. In 2024, it has also been seen the rate of cancer, lung cancer, has been very much increasing in women instead of men, and the liver and intrahepatic bile duct carcinoma deaths are increasing in men. Although the carcinoma of breast occurs about 2.5 times more frequent than the lung carcinoma, lung cancer now causes more death in the women. So now we come to environmental factors. Environmental factors, although both the genetic and environmental factors contribute, the environmental influence are dominant factors in most of the cancer. So these things will include the habits like smoking habits. Then it will include the environmental infections, that will include the like hepatitis B infection, hepatitis C infection, obesity. The tumors have also been linked to obesity. So United States and most of the other high income countries is prostate cancer, but the other countries or regions, cancers of liver, stomach, esophagus, bladder, and these things and the immune system rise in the top of the list. Similarly, incidence of breast cancer is generally higher in women living in higher income countries than in the lower income countries. Although racial predisposition may factor in, it is believed the environmental influences. So infectious agent, up to from all the malignancies, 15% of all the malignancies are due to infectious agents. That is, with the burden of cancer linked to infections being roughly 3 times higher in the developing countries. So over the world it is 15%, but if you are living in a developing country, this is up to 3 times more. That can be up to 45% of all the cancers in your developing country can be associated due to infectious agents. So the infectious agents are human papilloma virus and other viruses also there, discussed in the later part of the subject. Then smoking is very highly associated with cancers of the mouth, pharynx, larynx, esophagus, pancreas, and bladder. So there are 6: mouth, pharynx, larynx, esophagus, pancreas, and bladder. Then in up to 90% of the lung cancers. Then alcohol consumption is also been associated with increased risk of oropharyngeal, larynx, and esophagus malignancies, along with alcoholic cirrhosis that can end up in hepatocellular carcinomas. Moreover, the risk of cancers of upper airway and digestive tracts, these are very synergistic if somebody is consuming alcohol along with tobacco. Then the dietary factors, although they are very debatable and studies are going on, but they have been seen to have variations in colorectal carcinoma patterns, prostate carcinoma, and breast carcinoma with the diet. Then obesity. Obesity has been seen in the very developed parts of the countries. Obesity is associated and overweight is associated in 52% men and 62% women have higher death rates from cancer than to the slimmer counterparts. It is follows that approximately 14% of death in men and 20% of death are associated with obesity. Then reproductive history. So if a woman has not have any multiple pregnancies or even single pregnancy, she has a very increased exposure to estrogen for throughout her life. And if she has been exposed to estrogen without with unopposed progesterone, there has increased risk of breast and endometrial malignancy. Then we come to environmental carcinogens. Amongst the environmental carcinogens are especially in the workplace, if the people work in factories, they are exposed to carcinogens including the UV rays. Then especially if there are some places like in Bangladesh, even the water is contaminated with arsenic. Then if they take some medications like methotrexate or go to work where they are exposed to asbestos, or in the home they are eating grilled meat or high fat diet or alcohol, all these environmental situations expose them to malignancy. Then age is an important factor. Usually the older people more than 55 years, and especially a woman that is 40 to 79 years, or a woman that is 60 to 79 years, it's very much earlier in women, had increased risk of malignancy. The cancer deaths decline after 80 years of age, but this is due to because the people don't survive more than 80 years of age, so that's why the incidence also goes down. And this is with aging, the age factor is due to because with the age, as the people start to age, they start to accumulate a lot of mutations and lot of errors, so and also their DNA repair mechanisms weaken, so that leads to increased risk of development of malignancy. But as it is but in children's also it is very much high. Up to 10% of all the deaths in children are due to malignancies in children less than 15 years of age. So these tumors are usually not the ones that have been mutated due to environmental factor, but rather these are the children that have acquired these mutations from the parents. So most common malignancies in children is acute leukemia, followed by CNS that includes gliomas. These make up to 60% of all the cancer related deaths. And then there are small round blue cell tumors that are Wilms tumors. And these are all embryonal tumors, retinoblastoma, and acute ALL and rhabdomyosarcoma. Acquired predisposing conditions. Acquired predisposing conditions in carcinoma we divide into chronic inflammatory conditions and precursor lesions and immunodeficiency. Chronic inflammation, precursors, lesions span a diverse set of conditions. First, we'll come to chronic inflammatory conditions that predispose to. Chronic inflammatory conditions will include, like somebody is exposed to asbestosis, there is chronic irritation that can cause mesothelioma and lung cancer. Then there is IBD that can cause chronic inflammation of the GIT, followed by due to continuous irritation, increased proliferation. That inflammation causes increased growth factors, and increased inflammation cause activation of cytokines, more stimulation of growth factors. These growth factors are the cause proliferation. This proliferation increase the risk of with each proliferation there is increased risk of acquiring new mutations. With acquiring new mutations there is more risk of having driver mutations and finally leading to a cancer. Then we have lichen sclerosis that can further lead to vulvar squamous cell carcinoma. Pancreatitis, normal inflammation of pancreas, can lead to pancreatic carcinoma. Chronic cholecystitis, if the stones are left behind, it's an indication to remove the gallbladder. Then that is because the chronic irritation can cause gallbladder carcinoma. Then reflex esophagitis can cause esophageal carcinomas. Sjogren syndrome, Hashimoto's thyroiditis can cause multiple lymphomas. Then opisthosis cholangitis can cause cholangiocarcinoma. This is a parasite. Liver fluke, this liver fluke due to chronic irritation can cause cholangiocarcinoma and even colon carcinoma. Then H. pylori can cause gastritis, chronic irritation that can further lead to gastric adenoma, that we see now that because of good antibiotic coverage for H. pylori, it has led to reduced incidence of gastric adenocarcinoma, even multiple lymphoma. Then hepatitis B, hepatitis C leads to hepatocellular carcinoma. Then there is bacterial infection. Bacterial infections of the osteomyelitis can even lead to sinus tract carcinomas. HPV infections can cause cervical carcinoma, even oral malignancies. Then schizostomatiasis can cause bladder carcinoma. Then we come to these environmental exposures like arsenic that we have discussed. This can lead to lung cancer. So mostly everything is leading to lung cancer except for asbestosis that also leads to mesothelioma, benzene that also leads to acute leukemia, acute myeloid leukemia, then cadmium that leads to prostate carcinoma, nickel that leads to oropharyngeal carcinoma, and vinyl chloride that leads to hepatic angiosarcoma. The rest all leads to lung carcinoma. Okay, so it is explained. So what is a precursor lesion? Precursor lesions are the lesions that have high risk of developing into a malignancy. Like some changes like hyperplasia is a precursor lesion that can further lead to malignancy. A metaplastic change like Barrett's esophagus is a kind of metaplasia that can lead to malignancy, and dysplastic changes are also pre-malignant. So examples are like endometrial hyperplasia, if somebody is reported, that has high risk of developing into malignancy. If somebody is having villous adenoma, it has chance to develop into cancer in about 50% of cases if left untreated. And immunodeficiency, if first person is it is seen that CD8 cells usually fight with the tumor cells to save and prevent them from growing. But if somebody is immunodeficient, there is an increased risk of malignancy, especially with oncogenic, the ones with oncogenic virus. The great example is the people who have undergone transplantation usually develops B-cell lymphomas later on in their life after due to immunosuppressive therapies. Then genetic predisposition and interaction between environmental and inherited factors.